Okay, so we're going to move into part two. So we ended the last lecture looking at the different types of hormones that the book covers, and now we're going to start into discussing the homeostatic hormones. So just like homeostasis, which is trying to keep balance, these hormones are really involved in helping keep intracellular, extracellular environments functional, really in regards to functional essential pieces of life, but it also helps regulate what's happening inside your body based on what's going on outside, even outside in your environment. So an example would be this past weekend, I was hiking up along the Appalachian Trail, and it was cold this weekend. Remember Charlotte, it dropped probably into like the 40s at night and 60s during the day. Well, the highs up there were in the low mid to high 30s during the day, and it was in the low 30s at night, and there was snow. So my body, in response, since our body temperature likes to be about 98.6, it had to, even though I was clothed well, it still had to change my metabolism to increase the amount of calories that were burned to increase my body temperature, to keep my body at a relative 98.6, even though my environment was a lot lower. If I had been in Charlotte this weekend, it would not have worked as hard because, of course, I'd be sitting inside my house with my heat pumping. So there's less demand on the body to make that adjustment. But that's what we're talking about here. This is that adjustment in the hormones to improve or to have your system function well. All right, so we're going to use an example, and one is when it's a more common disease that we have, or that when we lose control of this homeostatic function, or we see a dysregulation, and it's on the rise in today's society. So we're talking about type 2 diabetes or diabetes mellitus. So if you're not aware of what this is, what ends up happening is the cells, because they're so when you have a functioning system, you eat food, your food gets broken down, you get glucose put into your blood, and if you're going to exercise at that moment, or you're going to do something strenuous, whether that's moving furniture around the house or walking from your car to your classroom, whatever that is, the glucose will be used by your muscles, by your brain. So those are things that are natural and normal. But often what happens is we eat enough food or more food than we actually need, and glucose stays in the bloodstream longer. And the body does not need that, and it prefers it not be there. So you'll produce insulin. And insulin is a message to cells to take up glucose. So the cells will take up glucose, and they'll use it if they can. If they can't use it, like fat cells don't use it effectively, they'll store it so that at some other future time, you might need to break down that fat to then use the energy in the future. But what ends up happening with type 2 diabetes is that we're putting in too much sugar into the body. There's too much glucose being present, and your then pancreas is mass producing insulin to bring up, for the cells to bring up the glucose. Well, the cells can only hold so much glucose. So what ends up happening is they become resistant to the insulin message. And that then causes the pancreas to make more insulin, because it's like, hey, you got to listen to me. You got to take up this glucose. We can't have this in the bloodstream. It's not healthy for the cells functioning. It's not healthy for the brain. I mean, the brain needs sugar, but it doesn't need that much glucose. So the pancreas continues to pump out more insulin, but it's not effective because the cells are no longer sensitive to it. And then you end up getting yourself into a state of hyperglycemia, which is having elevated blood glucose levels. And then again, as I mentioned, cells, whether it's your heart cells, your brain, your nerve cells, or if it's your muscle cells, they don't function in a excessive amounts of glucose. It's not a preferable environment, so they don't function well. So what ends up happening is that for type 2 diabetics, they often have to put in additional insulin that's synthetic that the body will still recognize and almost kind of forces the cells to take it up. But they also are supposed to really be regulating their food so that they're not having these excessive increases in blood sugar levels prior, when they're eating. So they shouldn't have this. It should be a more slow rise and then a slow decrease. But one of the things that does happen that is really serious for individuals who are type 2 diabetics is that if they aren't careful and they actually inject too much insulin, the body will respond, and then their blood glucose levels will drop significantly and too quickly and actually cause them to black out and have a whole host of very negative repercussions from it. So type 2 diabetes is really something that it shows the dysregulation of when you have too much strain on a system, so too much insulin, too much glucose in the blood, where the body then starts to make negative adaptations. But again, this is what is one way that we've seen dysregulation in the homeostatic world. Here's another example. So melatonin, do you have any idea? Pause for a second. Do you have any idea what melatonin does? I'm giving you a hint on the screen because it says circadian rhythm. All right. Okay, so hopefully you've thought through that just a little bit. And it turns out that melatonin does play a role in sleepiness and readying the body for going to sleep. So if you thought about that, if that's what you're like, oh, melatonin makes people sleep. Well, it does. It's not necessarily a trigger to immediately fall asleep. It does have an impact on preparing the body for changing the brain, getting it into a state where then it actively causes sleep to occur. So when we're looking at it, we can look at the change or the rhythm across the day. So one of the things about homeostatic hormones is that they often have some type of cyclical pattern. Melatonin happens to be circadian. Glucagon and insulin happen to be food driven. So when you put food in your body and then you stop eating and then you stay satiated and then you get hungry again, that's homeostatic. So there's some type of cyclical motion with it. So when we're looking at melatonin, we're talking about a daily cycle. So looking at a picture, so we've got on the y-axis, we've got the melatonin levels, and on the x-axis we have time. So this grayed out portion is sleeping time. And what you'll notice is that melatonin, when you're up, is typically really low. It's almost zero. And this is one of those hormones that I talked about a little bit earlier, that actually bucks the system with regards to whether or not the hypothalamus and the pituitary play a role. Melatonin is actually driven by exposure to light. Typically we think sunlight, ultraviolet light, but in reality we know that exposure to even artificial lights cause a major problem. So let's think about what I'm talking about. So let's say this is roughly this time of year, where we've got around the 7:30 p.m. level is where the sun goes down. Well, we get this little rise in melatonin that's called the dim light melatonin onset. So that then is an indication for our bodies, the sun's gone down, we should be getting sleepy, and we should be getting ourselves ready for bed. And as you'll notice, as you're starting to approach bedtime, you actually get this nice rise. And then when you're sleeping, you get this huge rise until you get close to starting to wake up. And then as you're starting to wake up, you start losing some melatonin. And then as soon as you wake up, as soon as light hits your eye, you have an immediate drop off of melatonin. So melatonin production is linked to exposure to light. So something that's important for you to think about, and as you all are probably sitting there reading or watching this, maybe you're doing it late at night. But one of the things that we've done to ourselves as human beings is, yes, we have the advantage to be able to have light any time of day that we want. But what we're doing is we're really messing up this circadian rhythm, this rhythm that our body needs to have itself restore and repair overnight. And it's not just sunlight that cuts off melatonin. It's all of our artificial lights. It's the screen on your computer. It's the screen on your smartphone. It's the screen on your TV. They're all emitting that especially potent level of blue wave that really activates the pineal gland to not produce melatonin. So you're effectively, if you're having problems sleeping, one of the things you should think about is if you have a behavior where you're sitting up doing homework or playing on your phone or watching playing video games or watching Netflix or whatever you're doing, if you do that right up to bedtime, you're actually very much influencing the amount of melatonin that's in your body. You're actually cutting it down. So the best thing to do is to shut all this stuff down, read a book, or meditate, or do something to put you in a space that allows you to be in a dark environment where you're allowing that natural melatonin rise. Now, I know you're probably like, oh, whatever, you sound like my mom, or maybe whatever, I don't know. But this is a very true example, and one of the things they started doing at hospitals. So if you think about it, if you've never been in the hospital, one of the things that we do is light is on constantly. And that is disruptive to patients who are sick, trying to heal, or recovering from surgery. Having that constant exposure, they're not getting that deep, real restful sleep. So what they've started doing, which is really interesting, is they've created glasses to put on the patients to block out the light. So we're talking about just removing, especially the blue light. And they've also added in lights that are not on the spectrum of blue light, so that it helps reduce for those to be turned on at night when the patients are supposed to be sleeping, but yet the nurses can still come in and do their jobs, or the attendees. The other piece that's important to understand is that the WHO, or the World Health Organization, actually, I think it was about 5 years ago, maybe 6 years now, actually decided that there's enough evidence that third shift work is technically a carcinogen. Think about that. Not sleeping at dark time is considered a carcinogen. It's considered to be enough of a link to developing cancer. So what does that mean? Some of you might work third shift. I get that. You got to make ends meet. I understand that completely. But what they're saying, and the reason why, is because the research has shown that individuals who work third shift, right? So that's working from 11 p.m. to 7 a.m., midnight to 8 a.m., whatever that range is. You're basically staying awake and working overnight. What happens is that even if you go home and you get yourself into a completely dark environment, the melatonin rise that you have while you sleep is never as high as somebody, even for yourself, as if you slept at night in the dark, because the body is so in sync with the rise of the sun and the setting of the sun, that this melatonin rise, and that this part that's not getting that full-on melatonin experience inside the body actually leads to a lot of negative repercussions over time. So I'm not talking about if you've done this for 3 years or 4 years. I'm talking about people who've done this for their careers or for their lifetime. Something to think about as you guys are thinking about your careers and moving on is that third shift work does pay better because you're working at a less desirable time. But if you do it for an extended period of time, it might really have some negative repercussions for your health. So just something to be aware of. All right. So now we're going to move into sex hormones, or gonadal hormones. And what's interesting about this is that sex hormones provide a way for us to talk about and think about how impactful, or the severity, you could think about severity, but the strength or the huge potential that sex hormones have on our bodies. They even affect us long before we're born. So we're talking about in utero effects. This is when you're in the womb, growing and developing. And then we also see effects that are continued throughout the lifetime. So there's two major effects that we're talking about. So one is the organizational hypothesis, or the organizational effects. And we'll talk about what that means in a moment. And then there's these activating effects. So these things that are causing changes in the immediate. So let's go back to organizational. Organizational effects are times when hormones are exposed at a very critical period. This is specifically during development, but very important period, where then it alters the future trajectory of that tissue. So let's take the human gonads, right? So when you're a zygote, right? So when an egg and a sperm come together, you get all that genetic material and the potential to be a human. You go into a zygote and then you become a fetus. So when you're in that fetal stage, you actually, for the first roughly 7 weeks, are completely asexual. You are undifferentiated. You have no sex. You have the potential to become a male or to become a female, but you actually have no sex. So around 7 weeks is when the Y chromosome gets turned on, if it's a male, and causes the testes, or takes the gonads that were undifferentiated and had no way, to be male or female, and changes them so that they start producing testosterone. And then that testosterone has organizational effects, where then the rest of the urogenital system will differentiate into what becomes the male the male plumbing, per se, to develop the penis and the longer urethra, and connecting to the bladder with then also the different glands that support male sexual reproduction. So all of those changes occur in utero, and it's because of exposure to testosterone. We're going to go in depth and we're going to talk about how testosterone actually goes on and masculinizes the brain. So if you think about that, testosterone has to be present for the fetus to become male and for the fetus's brain to become male. So what does that mean? It means that female is the default. Let's hear it, ladies. Just teasing. But anyway, so that is a true statement, that if testosterone isn't produced, even if that's an XY genetic being, fetus, if the testosterone isn't produced or there's no receptors for the testosterone, that fetus will go on and become a female, even if they have an XY chromosome. So this is that important thing. It's amazing that we have as many healthy babies that are born either as male or female, because all of these pieces have to work. All right, so that's what I talk about organizational, is that it's then affecting. So those testes, those gonads went from being not differentiated to producing testosterone and then supporting the masculinization of the whole fetus. That's what I'm talking about, organizational. That is how you change the trajectory of a tissue from one to another. So looking at activating effects, this is having a more immediate impact, and not necessarily longer term per se. But these would be examples of when you're looking at sex-related behaviors, mating behaviors, or sexual desire, libido, right? So testosterone in males often is linked to having higher libido. For females, this is a joke, but it's true. Ladies, if you're all of a sudden if you're not on any oral contraceptive or any type of hormonal contraceptive, if you're, all of a sudden suddenly attracted to one of your classmates or whatever, you might want to take a step back, because that might mean you're releasing estradiol, which means you're at your peak ovulation, which means you're primed and ready to go to get pregnant. So you might want to rethink that if all of a sudden someone that you've never been attracted to all of a sudden is super cute. And then men, if all of a sudden someone's super interested in you, you may want to run away or at least protect yourself in some way, because what our bodies are, and that's what those sexual hormones are for, is to ready us and prime us for the creation of the next generation, and facilitating that. So these are what we would call activating effects, things that are not necessarily affecting the trajectory, but are immediately having an impact. All right, so what are the reproductive hormones? Just want to make sure we cover all of them. So we have androgens, and we've been talking about those, and there are actually several different types. But for this course, all you need to recognize is that testosterone is an androgen, and it is produced in the testes in males. Now, as we've said, I've talked about oxytocin and vasopressin being sexually dimorphic. Testosterone is also sexually dimorphic, and that both males and females have it, but it is elevated, or males have more of it. Then we have estrogens. And we'll talk about two specific ones, or we've talked about two specific ones, or we'll get around when we talk about the cycle a little bit. It turns out that estrogens like estradiol and progesterone play a key role in managing or allowing for the menstrual cycle in females. So again, estrogens are sexually dimorphic. Both males and females have both estradiol and progesterone, but they are much higher and have a greater effect in females. So estradiol is the one where when you're ovulating, it peaks. It's this huge rush or release of estradiol. And if you're ovulating, that is when for females, is when they're the most interested in having sex. And then what ends up happening is progesterone also elevates, but if the woman doesn't get pregnant, both the estradiol and progesterone drop off, which then stimulates the sloughing of the uterus, which is a menstrual cycle or a bleeding or the period. So that again plays a huge role in females, but not necessarily so much in males, although males do have it, because there are processes, there are enzymes in our body that for males can take testosterone and turn it into estradiol or progesterone, and in females we can take the pathway, and we can then create testosterone and have it present in our bodies. So now let's look at pituitary hormones. There are actually 4 that are related to reproduction. So we've got follicle stimulating hormone and luteinizing hormone. Those are both, again, playing key roles in the timing of ovulation. So those two actually, follicle stimulating hormone goes up, and then estradiol responds back. So this is a two-way communication that goes on. And then the luteinizing hormone and progesterone, those kind of steady out until then there's no, if you don't get pregnant, then those hormones go away, which is what brings on the period. Prolactin and oxytocin. Prolactin plays a role in the milk letdown, as I talked about, so nursing, and oxytocin plays a role in bonding and pair bonding and being connected. It increases, so oxytocin also plays a critical role in labor and delivery, where contractions are the oxytocin induces contractions. But we also know that it plays a role in mother to infant bonding, as well as there are studies that have shown that dads who bond well with their infants also have elevated oxytocin levels. Just physical human touch can increase. So whether or not you're human to, mother to baby, or whether you're partner to partner or friend to friend, just physical touch has shown that increase in oxytocin. It's not going to be sexual or anything like that, just touching someone else's arm in a gentle way or whatever. Not hitting someone, that doesn't work. But just being in touch and having skin-to-skin contact can increase oxytocin. All right, so we're going to move into now. So we've talked a little bit about how the sexual hormones have a major impact on the development of, whether you are a male or a female, whether you have internal or external plumbing. So now we're going to talk about what happens in the brain. So in the uterus, in utero, when the fetus is developing, we can actually see that there are changes in the brain. Now we can see this in animals. I don't think there's been human studies that have looked at brain scans of infants and adolescents, but there are ones that have been done in adults and some older adolescents, where we can actually see differences by sex. So again, sexually dimorphic, right? So they are brain areas that develop differently based on the sex of the person. And now when I talk about sex, if you've noticed, I've been very clear. I have not used the word gender. Gender is not what we're talking about. Gender and gender identity is a very complex issue that is something that I talk about in my next course. So 3113, if you're really interested in this kind of stuff, you'd want to take that with me. I'm teaching it this summer online. But that's kind of stuff that we get into a little more depth to look at how gender is impacted by some of this biological stuff. But right now I'm really just talking about sex. So XX, XY, whether you have internal plumbing, which is female, or you have external plumbing, which is male. That's what we're talking about. So we see these effects, and there are two that are pretty well established that you should be aware of, and there are others, but just for the nature of this course, there are two areas. So one is the hypothalamus. Men actually have a larger volume of the hypothalamus when we're measuring it in the brain. And then the corpus callosum is larger and more integrated in females. These are just two areas that we know. And then this comes right from your textbook, where the purplish blue areas are places where the female brain has greater density and better connections. And then the pink areas are places where the male brain have better interconnections and better wiring or higher volume, which may give rise to things like males are better at spatial orientation. Females are more verbal, right? So linking the corpus callosum, which brings the two halves together, integrates both the verbal and the nonverbal communication, and the detail-oriented and big picture-oriented. So maybe this is why females often talk through things more, because these two sides of the brains are integrated. So how does this happen, or why does this happen? Well, it turns out that when in utero and the brain's developing, systemic testosterone, so the testosterone is being pumped out by the testes of a male fetus, get in the bloodstream and then pump all over the body. And when it does that, it gets to the brain. And then because testosterone is a steroid hormone, it can easily cross into the brain. And when it gets into the brain, the neurons actually take it and turn it into estradiol. And this change from estradiol then supports all the changes, the masculinization of the brain. So we're going to talk about what that looks like in a moment. But I want, you might be sitting there going, well, wait, if estradiol is actually causing the changes in the brain, why don't females have a masculinized brain? Maybe you didn't get there yet, but you will when you think about it, right? Because female fetuses have more estradiol pumping around in their bodies than males do. But what we know is that estradiol, systemic estradiol in female fetuses, are actually inactivated by an alpha fetal protein. So that means that the estradiol is bound to another protein that makes it so big it can't cross into the brain. So that's why systemic estradiol has no impacts. However, systemic testosterone can get into the brain because it's not bound up by this protein, and then the neurons actually transfer it into estradiol to have the effects. So what do these effects look like? Well, certain areas of the brain are super sensitive to the exposure of testosterone / estradiol. So thinking about the hypothalamus is one area. And what it does is you have the number of neurons that are formed or that die off change based on exposure to estradiol. Then cell growth, how densely populated it is. And then when you start thinking about neuroplasticity, so changing how well different parts of the brain are integrated, estradiol also influences dendritic branching, synaptic growth, and activity of different synapses. So this is true in utero, but it's also true once you're outside of the womb, that the brain can be impacted after all these organizational effects by changes that occur in the brain as a toddler and adolescent, and then into adulthood. So these are all things that we can see. So when we talk about the organizational effects, that's what we're talking about. We're talking about the urogenital system transferring either into a male or female, and then we're talking about the brain either being masculinized or not. So that's what we're talking about with organizational. The activational things are like libido, and that's like when males from like the ages of 17 until like 26 nonstop think about sex. That's what we're talking about. Those are activating effects. For females, when they're ovulating and you have that peak in estradiol. That's what we're talking about, that increase of libido. That's activating. Okay. One other thing I like to touch on with undergraduates is to discuss anabolic and andronergic steroids. It's a big thing in sports. Typically, players use them to try to help increase muscle mass. Is really the goal. But just so you have an idea that there are common things that occur which are typically actually a health risk. So anabolic means the ability to build muscle. So that's usually why people are dosing themselves with testosterone or with these steroids, is because it mimics the male testosterone hormone to increase muscle mass. But it also has androgenic effects, which means masculinization. So if you notice, what that often does is it can, especially in females, deepen their voice, or it can start body hair growing on their face in places that it didn't happen before they started doping or using the steroids. And in males, what ends up happening is if they're excessive users of it, you might hear that they actually start to develop gynecomastia, which is increasing their breast tissue. So the male body can only handle so much exposure to testosterone. And what ends up happening is then the body starts converting it to estradiols and progesterone, which is then why sometimes males start to develop some enlargements of their breasts when they're using these steroids, and also then the shrinkage of their testicles, because their body no longer needs to produce the testosterone on their own, so that system kind of shuts down. So looking at health risks, so the body basically reduces production of testosterone, as I got to there at the end, which means male fertility can decrease. We also, if you've ever heard of roid rage, not road rage, but roid rage, that's talking about the increase of aggression that occurs in users of anabolic steroids. There's also an increased risk of heart attack and stroke, and that also can influence how well your kidneys and liver function. And then finally, as I mentioned, females actually can be masculinized, which means that they develop a deeper voice, they start growing facial hair, having secondary characteristics that look male-like. They also get the increase in muscle mass, which is what they're going after. All right, so that is the end of the sex hormones section. And in our last one, in my very last lecture, we're going to pick up with looking at glucocorticoids and cortisol in stress.